Chers professeurs, chers confrères, chers amis, bonsoir. Après le succès de la première édition, l'Association marocaine des jeunes ophtalmologistes revient ce soir, comme promis, pour explorer les explorations dans une ambiance jeune et détendue. Sans plus tarder, avant de commencer, j'aimerais tout d'abord remercier la Société marocaine d'ophtalmologie et l'Académie marocaine d'ophtalmologie pour nous avoir octroyé leur parrainage et pour leur confiance. Nos remerciements vont également à Promu Médical, représentant Topcon au Maroc, pour avoir sponsorisé et accompagné cet événement. Le choix des explorations comme thème du webinaire de ce soir n'est pas anodin. En effet, les explorations fonctionnelles font partie de la pratique quotidienne de tout ophtalmologiste. C'est pour cela que nous vous réservons ce soir d'éminents orateurs nationaux et internationaux, tout aussi passionnés d'ophtalmologie que généreux de leur science. Avec nous ce soir, le président de la Société marocaine d'ophtalmologie, le docteur Mohamed Bennani, mais également le professeur Cherkaoui du service d'ophtalmologie A du CHU de Rabat, le professeur El Maloum du CHU de Casablanca, le docteur Trissi de Casablanca. Puis, comme à l'accoutumée, nous allons traverser les frontières et rejoindre un grand ami des Marocains, le professeur Eric Sued du CHU de Créteil et le docteur et monsieur Adil Mftouhi de Lyon. Puis nous allons atterrir à Dubaï pour rejoindre un passionné de topographie cornéenne et de chirurgie réfractive, le professeur Mazen Sinjab. C'est également toujours un grand plaisir pour moi de vous présenter l'équipe de l'AMJO. Avec moi ce soir, 4 autres jeunes modérateurs et membres du bureau de l'AMJO, à savoir le docteur Soukaina Bouzienne du CHU de Casablanca, le docteur Younes Aknour du CHU de Rabat, le docteur Amin Haddad du CHU de Casablanca et le docteur Amina Wadfil du CHU de Oujda, connectés ce soir de Granville. Sans plus tarder, docteur Amin Haddad, je te donne la parole pour lancer le webinaire avec notre première oratrice. Merci, chers orateurs et chers spectateurs, pour être parmi nous dans ce webinaire. Merci à tous.
Merci beaucoup, Madame la Présidente. Bonsoir. Et à mon tour, j'ai l'immense plaisir de modérer ce webinaire à côté de mes chers collègues. On ne peut pas parler des explorations en ophtalmologie sans parler de champ visuel. Cet examen essentiel, incontournable dans la pratique quotidienne de chaque ophtalmologue. Et pour ceci, nous avons avec nous ce soir ma professeure et mon mentor en ophtalmologie, Madame El Maloum, professeure d'enseignement supérieur au service d'ophtalmologie pédiatrique au CHU de Casablanca et également experte en glaucome pour nous rappeler les bases du champ visuel et nous montrer comment interpréter cet examen d'une manière didactique. Chers collègues, préparez vos stylos, préparez vos blocs-notes parce qu'aujourd'hui, vous allez avoir des conseils et astuces utiles et pratiques. À vous la parole, professeur El Maloum.
Présentation qui nous a fait voir beaucoup de choses concernant l'échographie. والآن يشرفني أن أرحب بالأستاذ سنجاب الذي يمارس بمصحته الخاصة بدبي والذي يعد من أبرز الباحثين في مجالي التوبوغرافيا القرنية وجراحة الانكسار والذي ألف العديد من المراجع. فبدون المزيد من التأخير أود أن أشكرك أستاذ سنجاب على استجابة الدعوة. فتفضل مشكورة لكي تقدم لنا أساسيات توبوغرافيا القرنية.
شكرا جزيلا. الصوت مسموع؟
نعم أستاذ، الصوت مسموع.
Okay. السلام عليكم ورحمة الله وبركاته. Thank you very much for this kind invitation. Actually, it is my honor to be with you. Now I'm going to share my screen in order to gain time. So what I'm going to talk about today is the basic of tomography as requested from me. Now, because it is just 15 minutes, I'm going to compress the whole tomography science, which needs books to be covered. I'm going to compress it within only 15 minutes to make it as easy as possible, and especially in terms of refractive surgery. Now, I advise everyone to study the following maps when anyone would like to decide regarding to go or not to go for the refractive surgery. The first map is the 4 refractive map. The 4 refractive map consists of 4 maps: the sagittal curvature front, the elevation anterior, the elevation posterior and corneal thickness. In addition to the relative backimetry map, it's very important, as we will see later, and the corneal thickness profiles. So we have three things to see. The very important point is to compare both eyes. We cannot make a decision just by depending on one eye. So whenever you see a topography of one eye, don't make a decision until you see the other eye. Now, we have to compare both eyes in terms of 5 parameters, as you see in this table. We compare the mean K on the anterior surface. We compare the mean K on the posterior surface. We compare the thinnest backimetry. We compare the elevations on the anterior and posterior corneal surfaces at points corresponding to the thinnest location. So we look where the thinnest location is, and then we look at the number on the elevation map that's on the thinnest location or just beside it, and then we compare both eyes. Why is this? Because usually in normal people, there must be no much difference between both eyes. There must be maybe 1 or 2 or 3 differences, but whenever we have 4 differences, there, it is a suspect case, and if we have 5 differences, then it is a risky case. So let us start with the 4 refractive map, which consists of the anterior sagittal curvature map, which measures the power of the eye, of the cornea, of the corneal surface, I mean, and the anterior and posterior elevation maps, in addition to the corneal thickness map. Now let's see what we have to look at on this map. Very easy. We start with, first of all, we have to validate this map. Not every map that comes to our hand is valid or is accurate. So we have to be sure that this map is accurate, has been taken or has been captured in like the ideal situation. Otherwise, if there are some factors of false findings, then there will be misleading diagnoses and wrong decisions. Sometimes the wrong decisions may lead to exclusion of proper candidates. I mean, for example, maybe the candidate is very good for the refractive surgery, but because of the false findings, we may think, no, this map means there is risk and we cannot do refractive surgery. On the other side, sometimes the wrong findings or the false findings may hide some risky factors, so the cornea may appear normal, although it is not normal. So in this case, we are going to include risky people into the refractive surgery. So to avoid all of this, we have to validate, and we have to be sure that this map is accurate. We start with the quality specification. The quality specification should be white, okay. If it is not white, okay, then we have to reject it. If it is white, okay, we have to be sure that the displays are in the 9mm magnified. We have to see the maps magnified. Then we have to be sure that whether we are studying the elevation map in best fit sphere or best fit toric ellipsoid, we have to be sure that the diameter is 8mm. It's very clear here that the diameter is 8mm. If the diameter is not 8mm, we cannot make a decision. You have to reject the picture. Then we have to be sure that the periphery of the curvature map is clean without black dots. If there are black dots, it means that there are missing data and there are extrapolated data, false data. So we have to reject it. And finally, we have to compare pupil center coordinates between both eyes. Why is that? Because we have to exclude the misalignment during taking the capture, because the most common cause of false findings is misalignment during taking the capture. The patient, maybe he was not looking at the fixation target while the camera was taking the capture. So in this case, we are going to have false findings, especially
the skewed radial axis or the inferior steepness, which maybe they are not there, but because of the misalignment, they appear there on the map. Now, on the pupil center coordinate, what are we going to do is to compare both eyes. How we are going to do this, as you see here, this is the pupil center coordinate of the right eye and of the left eye. I put this formula in order to check the misalignment and differentiate it from large angle kappa. We have to follow this rule. X plus X should be less than 200 microns, and Y minus Y should be less than 200 microns. I'll give you some examples. This example, as you see, X plus X is less than 200 microns. It is only just 60 microns. The 0.06 millimeter, as you see on the right side, then it means 60 microns. And of course, we have to take into consideration the algebraic sign. So X plus X should be less than 200 microns. This case is less than 200 microns. Y minus Y, so the plus 0.05 minus plus 0.03, it is just 0.02, which is 20 microns. So it is less than 200 microns. So in this case, there is no misalignment. This is another case where we can see asymmetric coordinates and misalignment. The X plus X is less than 200 microns, but the Y minus Y is 260 microns. So it is more than 200 microns. So there is vertical misalignment. The patient was looking downward in one of the eyes while taking the capture. This is another example. The X plus X is more than 200 microns, and the Y minus Y is more than 200 microns. So there is vertical and horizontal, so oblique misalignment. Now, this is a case of large angle kappa. As you see here, we find that the X coordinates are very large, 680 microns in the right eye and 690 microns in the left eye. In spite of this, there is no misalignment because X plus X is less than 200 microns and Y minus Y is less than 200 microns. So these large numbers are not because of misalignment, but because of large angle kappa. Now, let us start by looking at the following points. The first point is the KM. We have to check the anterior KM. The anterior KM, the cutoff value is 48 diopters if we are depending on the Pentacam, and if we are depending on Placido-based, including, of course, other machines that Placido is part of, like Cyrus, Galilei, the new OCT, all of those, because they depend on the Placido and measuring the curvature. So the cutoff value is 47.2. So in the Pentacam, the cutoff value is 48 according to Jack Holliday, while in Placido-based, the cutoff point is 47.2 according to Rabinovich. Now, I divide the risk factors based on the KM into moderate risk factor when it is 48.1 up to 50, and high risk factor whenever it is more than 50 diopters. The second point is the thinnest location. Now, the thinnest location is debatable because it is based on population and it depends from study to study. So based on the international multi-center study that I depended on, based on that, the cutoff value is 500 microns. Whenever it is between 470 and 500 microns, it is moderate risk. And whenever it is less than 470, it is high risk, because according to this international multi-center study, less than 2.5% of normal people, they have less than 470 microns. But as I told you, it may depend on the population. For example, in North Africa, for example, in Morocco, There is a study which was published by Dr. Muhammad Shahbi and Dr. Colin, I think. It shows that the thinnest location is less than this in normal population. So as I told you, this should be adjusted according to the population. We come to the sagittal curvature map. We have to look at two things in the sagittal curvature map: the inferior superior asymmetry and the skewed radial axis. Just two things. The first thing is the inferior superior asymmetry. The best way in the Pentacam is to go to the topometry page and look at this value, which is IS. Whenever it is more than 1.4, then it is considered abnormal. However, if the software is not updated, you cannot find this. So very easy, you can go to the steep axis at the 4 millimeter zone and you compare the two opposing points. If the superior point is larger in value, then you have to consider superior minus inferior should be more than 2.5 diopters. While if the inferior value is larger, then we have to consider inferior minus superior, and it should be less than 1.5 diopters. Otherwise, they are considered abnormal. Now, we can let's say, ignore this sign. I mean, suppose you found inferior superior asymmetry, and you have the facility to have the corneal mapping. Now, if you find there is a corresponding focal thinning in the epithelium, then you can consider the inferior superior asymmetry as important. But in many cases, actually, the inferior superior asymmetry is not associated with the focal thinning in the epithelium. Sometimes it is associated with thickening, corresponding thickening, especially when using the contact lenses. So not every inferior superior asymmetry should be considered. So if you can have the facility to measure the epithelial mapping and you find that there is no epithelial thinning, then you can ignore the inferior superior asymmetry even if it is high. Now we come to the second point on the sagittal curvature map, which is the skewed radial axis. We look at the central parts, as you see here, the red arrows. If the angle between the inferior and superior is more than 22 degrees, they should be aligned. But if the angle is more than 22 degrees, it is considered high risk. Now, even this, we can ignore it in the following cases. The first case is when you have enantiomorphism, which means that both eyes are mirror shape, just mirror shape. This eye is a mirror of this eye, so you can ignore it. The second thing is whenever you have large angle kappa. If you have large angle kappa, this sign is pseudo. This sign is false because of the large angle kappa and the capture is insignificant. These shapes are always high risk, regardless of the numbers, regardless of the inferior superior asymmetry or the skewed radial axis. So whenever you have butterfly, crab clone, vertical D, a clone pattern, then all of them is high risk. Then we move to point number 4, which is the elevation map. Of course, we have to study the elevation map in the best fit sphere and best fit toric ellipsoid. The best fit sphere is recommended by Professor Bellin and Professor Ambrosio, while the best fit toric ellipsoid is recommended by Professor Holliday. But the cutoff values differ. The best fit sphere, and remember again, it should be an 8 millimeter. The best fit toric ellipsoid should be in 8 millimeter as well. So the best fit sphere, 8 millimeter, you look at the thinnest location, you look at the value corresponding to the thinnest location, as you see in the red arrows, and then according to the refraction of the patient, the refractive error, you can decide the cutoff values. If the patient is myopic or emmetropic, the cutoff values are 8 microns plus 8 microns. All these numbers are in plus 8 microns for the anterior surface, plus 18 microns for the posterior surface. And if the patient is hyperopic or has mixed astigmatism, then the cutoff value for the anterior is plus 7, and for the posterior is plus 28. So if you find any value above these cutoff values, then it is high risk. The best fit toric ellipsoid, 8 millimeter, again, you have to remember, we look within the 5 millimeter central zone, the central 5 millimeter zone. Any value within the central 5 millimeter zone, more than 12 microns plus 12 microns on the anterior surface, or more than plus 15 microns on the posterior surface, they are considered as high risk. Now we come to point number 5, which is corneal thickness. Don't look at numbers. Don't look at inferior superior asymmetry. Just look at the pattern. The pattern should be concentric, as you see here. If you see the dome shape, which is the vertical displacement of the pattern, or the droplet sign, then you can consider it as moderate risk factor. And if you see the bell shape or the globus shape, then it is high risk factors. Point number 6 is the profiles, thickness profiles. We have to look at the red line of the captured cornea, and we have to look at it in terms of shape, just shape. Don't look at the position. Don't look at whether it started just near the 400 microns or near the 600 microns, because 400 microns means that the cornea is thin, just thin, but does not mean that the cornea is abnormal. We have many normal corneas which are about 440, 450. And we have diseased corneas which are 600 and above. So no matter where the red line starts, but it matters how it goes, okay, how homogeneous, or how, let's say, the slope of the red curve. It should follow the slope of the dotted lines. The dotted black lines represent the normal population, the standard deviation of the normal population. So it should follow the slope of those. And our reference part is the 6 millimeter. I will show you later what does that mean. Now, in addition, we have to look at the average. Look on the bottom, you'll find the average in red. Now, the average in red, it should be less than 1.2. It should be 1.1 and below. If it is more than 1.1, it is considered as abnormal. Now, I'll show you the abnormal shapes based on the profiles. The first one, which is moderate risk, is the S shape, where the S goes up just after the 6 millimeter, not before, as you see in this case. The other moderate risk is whenever the slope is very normal, as you see here, but the average is very high, more than 1.1. It is 1.5. So this case should be considered as moderate risk. Now, we can ignore this shape in particular when we see that the slope is very regular, but the average is high. We can ignore it as well and consider it as normal when all other criteria on the maps are normal, and we have only just high average, and the cornea has high astigmatism. Because I noticed that in high astigmatism, when the cornea has more than 2 diopters of tomographical astigmatism, in many cases, the average is high, but all other parameters and maps are normal. So in such case, you can ignore it as well. Now, this is one of the high risk factor, which is the quick slope. As you see, before the 6 millimeter, the slope descends very quickly, goes down very quickly. So this is high risk. The other high risk is the S shape, where the S starts before the 6 millimeter, as in this case. The other high risk factor is the inverted, because it goes up instead of going down, and this is a hallmark of pellucid marginal degeneration. We find it only in pellucid marginal degeneration, but not every pellucid marginal degeneration has this mark, let's say. Now, point number 7 is the relative backimetry map. The relative backimetry map helps us a lot to see whether the patient had previous refractive surgery. I'm not going to go into details in this case, but we look at any number over the whole map, but in the 9 millimeter display. Remember, all maps should be in 9 millimeter display. Okay, any number should be, let's say, 8 and above, -8 and above. In algebraic, -8 and above in algebraic means -5, -3, -2. And if it is less than -8, for example, -12, it is considered as moderate risk. This is an example of abnormal relative backimetry map. We can see that there are -15, -14, -10. So this is an abnormal one. Finally, we come to number 8, which is the inter-eye asymmetry. As I told you, we compare both eyes, the values of the KM anterior, KM posterior, thinnest backimetry, and the elevations corresponding to the thinnest location on the anterior and posterior elevation maps. We compare both, and in case of 4 differences, it is moderate risk. 5 differences, it is high risk. After we study both, then we can summarize what we found into a table, and this is the table. I named this the Practical Subjective Scoring System, the PS3. This is the latest update of my way in reading the Pentacam. At the same time, I have similar tables, but modified tables for the Cyrus and the Galilei, with all exceptions that I mentioned here in the footnote of the table. Now, after categorizing the risk factors into moderate risk and high risk, okay, how I'm going to apply what I found on refractive surgery? Very easy. If I found no moderate risk and no high risk, then I can go for whatever I like. Surface ablation, for example, PRK, SMILE, or LASIK. But if I found one moderate risk factor, then I cannot go for LASIK. I can go for surface ablation, I can go for SMILE. And if I find 2 moderate risk factors in one eye or 1 high risk factor, then I don't go for refractive surgery. Now, if you are going to apply this table on your daily practice without taking into consideration validating the accuracy of the capture, you will find yourself excluding a lot of patients from the operation. So first, validate the capture. Be sure that it is accurate and it is identical according to the international screening guidelines that I mentioned in the beginning. After that, you can make the decision and you will find yourself on the safe side. All what I said and a lot more regarding how to make the decision in laser-based refractive surgery, lens-based refractive surgery, and cataract refractive surgery based on topography, I mean the Pentacam tomography, are in this book, which is being published nowadays. So I advise everyone to read it. And thank you very much for your kind listening.
شكرا جزيلا أستاذنا على هذا العرض الشافي الكافي حول أساسيات توبوغرافيا القرنية.